Right. I'm going to introduce you to our teacher today. It's Mr. Alistair Laidlaw, who is a leading UK consultant ophthalmologist specializing in vitreoretinal surgery. He's had over 25 years of experience treating conditions such as retinal detachment, macular holes, membranes, also does cataracts, diabetic retinopathy, macular degeneration. The list goes on. He was trained in Newcastle, Bristol, and at Moorfields. He is obviously one of our consultants at St Thomas's in the South East London patch and at Maidstone Hospital, and has been there, been with both of us since 1998, I believe, Mr. Laidlaw.
Yeah,
He also runs a private practice at the London Clinic. He's a prolific researcher, a number of articles and papers, over 70, I believe, all related to vision measurement. Also done stuff with electronic record keeping. He's deeply involved in training future surgeons as well, and has had prominent leadership roles, including past president of the British and Ireland Association of Vitreoretinal Surgeons and the presidents of, I'm going to say it wrong, Uretina? No,
yeah.
Uretina, since September 21. So
Mm.
over to you, Mr. Laidlaw. Thank you very much.
Hi. Well, look, thanks for asking me. Well done, midsummer, beautiful evening. What on earth are you doing watching the telly? But here you go. Oh God, where's it gone? I had it a minute ago, didn't I? Here we are. So we're going to talk about the vitreoretinal interface disorders. Now, there was a suggestion that microphones are turned off. Please do interrupt. Please do ask questions. I really, really don't bite. And if you don't understand what I'm saying, or you're left with any doubt, it's much better to get out because you're not going to be the only one in the room who's in that position. And believe you me, just talking to the screen can be you just can't see what's going on. Anyway, so look, the vitreoretinal interface disorders, this is me. That's all been done. If anyone wants vision measurement software, the world's best can be found under that name. There we are. So what are we going to talk about? We're going to talk about epiretinal membranes, the melomacular holes, vitreomacular traction, and full thickness macular holes, and they're all a continuum. And that's a really important thing. And there's quite a lot of crossover between the two. The other thing that we're going to do, which isn't on here, is I'm going to introduce you to something called the Muller's cell cone. And the Muller's cell cone is a fascinating little bit of the central fovea, and we'll talk about that when it's relevant, that really is very important in terms of the way that all of these conditions evolve. A lot of the pathology with it. And the other concept we're going to talk about is something called vitreoschisis. Now, we kind of think that the vitreous is attached. It's like the bladder of a football, lines the inside of the eye. The collagen fibers lie along the surface of the macula. When you get a PVD, it all comes off cleanly. That's not what actually happens. Collagen, you often get the vitreous splits, vitreoschisis. Vitreoschisis underlies vitreomacular traction, underlies lamellar holes, underlies full thickness macular holes. Collagen is left on the surface of the macula in a large proportion of PVDs, and that acts as the scaffold for an epiretinal membrane. Please do interrupt. So let's talk about epiretinal membranes. I've taken illustrations from journals and from the system at the London Clinic. You'll be able to see which ones are publications, which ones weren't. If you want to know where they're from, I can tell you. So an epiretinal membrane. Can you see my cursor moving?
Yes, yes, we can. Yes.
Brilliant. That's really good. So an epiretinal membrane. Well, firstly, you've got this thing called vitreoschisis, and collagen is left on the surface of the retina. And then there's a bit of an insult, and that gets organized and contracts. Now, when we're looking at the macula with an epiretinal membrane, we can look at it in two ways, and these are a bit small on this side, but I find the en-face image, these are from Heidelberg, these are infrared reflectance images on the top con that we have down in Maidstone, we get a color image. I find this the infrared XY plane um, image really, really useful. And the thing that I like to look out for are the sort of fingerprint-like striae on top of the new vessels, on top of the blood vessels, and that shows you how it's crumpled up. That shows you the surface crumpling of the retina. And we all know that epiretinal membranes cause distortion. Now, so in epiretinal membranes, you can have surface corrugation, and the corrugations that you see in the en face images corresponds to these little corrugations on the surface of the retina. These are complete false constructs of what the retina actually looks like. It's much more curved than that on the bottom line. We all know that the have you played with your OCT in this way with the measurement device? The x-axis there would that distance there would be about 500 microns. This distance here would be about 200 microns. So the x and the y. Oh no, well, this is the z-axis, isn't it? Sorry. The z-axis is grossly enlarged compared to the x-axis or the y-axis. So we're seeing this falsely. But if you think about the inside of the retina, it's meant to be a curve. You lay down a scar on top of it, it contracts, and an arc, a nice curve, turns into a chord, a straight line, and that's why you get this sort of contraction. Epiretinal membranes, they form, they've got myofibroblasts, myomuscle fibroblasts, they contract, and they will contract over years. And if you keep looking at people with epiretinal membranes, they do get worse slowly. Threshold for intervention, as I'll come to, is still symptomatic distortion, but they do tend to get worse. But the other thing is that you get intraretinal change. Here, you can see the outer nuclear layer there, which are the photoreceptor nuclei. That's going up to the tip of the up to the base of the umbo, up to the base of the fovea. Here it's going up to the base of the fovea, but everything's a bit distorted. But you can see here on the corresponding one, we've got this extra layer, and this is ectopic inner retinal layers. So you've got this proliferation not just on the surface of the retina, but you're also getting a proliferation in the retina, particularly in the ganglion cell, the nerve fiber layer. I don't know that there's a huge amount of histopathology on this to say what's actually occurring and where, but in that this is living histopathology, we can see this. And then if you go to the really extreme end, which is pretty rare but definite, you get disorganization of the retinal layers, and that's the end point of lots of macular pathologies, that the diabetic retinopathy, vein occlusions, you get disorganization of the layers. So you can't work out, okay, that's the nerve fiber layer, then there's the ganglion cell layer, then there's the inner plexiform, then there's the inner nuclear, etc., etc. You can't work that out in here. Well, you know what's where. Right.
Mr.
John.
Laidlaw, just a
Yeah,
quick
hi.
question.
Yeah.
With these, then, is the interruption or disruption to the vision correspondent to the what we see on the OCT? I mean, so say for example, stage 3 looks so much worse than stage 2. Is the vision notably worse as
Yes.
of
Yes. Basically, there is a correlation. There's a lot of overlap, and I think if you flip that round, having looked at a lot of these for a long time, I can look at a scan and say, look, I think the acuity there is such and such. I think, I don't think that that's compatible. This here is compatible with, if we use old numbers, 6'9", nothing worse than 6'9" with this. So if the patient's claiming 6'36", they've got a cataract or there's something else going on. So there is a definite correlation between the image and the vision. And this here, likewise, I would expect to have poor vision. This one I'd expect to be about 624 probably in old money. And this, you'd expect to be 660 or less. So yes, there is a definite correlation. The other interesting thing there, and thank you for the question, is why do they get distortion? Because the fovea is usually in the right place. And it may actually be that the bipolars are a bit of a tart and change their allegiance. that because the surface is very crinkled, the outer retina is often not affected at all. And it may be that this is hypothesis from a guy whose name will come up later, that the bipolar cells may actually be moving to a different photoreceptor. And that may be that your normal XY positioning of the photoreceptors is gone, because the crinkling does appear to be predominantly on the inner retina, not on the outer retina. Anyway, that's just an interesting aside. So what are we looking for? High signal, correlation, and here we go, Muller's cell cone. So the Muller's cell cone, we'll come to that in a minute, is a little plug, almost a bit like a golf tee stuck in the middle of the fovea. It holds the fovea together. But you can get the where's my pointer gone there? You can get the traction coming through and pulling up the outer retina. And so you get this thing called a cotton ball, and that can actually go on as far as generating a little retinal detachment because of the pulling from the outside through the Muller's cell cone into the subfoveal space. So epiretinal membranes, basically it's surgery or no surgery. And is the patient having enough of a problem that they want something done about it? So what are the important things? Well, they can have impaired acuity. I think more important than impaired acuity is actually the amount of distortion, because it's very difficult to fuse a distorted image, sort of a Salvador Dali image, with a nice, regular, organized image. And then you get distortion, and you can get double vision, and you can get double vision because the fovea is pointing in different positions, and you can get interference because corresponding points are in different positions. And so people can end up with the eye interfering, and that brings in concepts like rivalry, where the binocular system likes to work together, but it will go right eye, left eye, right eye, left eye, right eye, left eye. And if you've got the same image in both eyes, then it doesn't matter that you're flipping right and left. But if you've got a different image in both eyes, it might depend on the dominance. And so dominance is actually very important in this. So non-dominant epiretinal membranes are much more, dominant eye epiretinal membranes are much more symptomatic than non-dominant eye epiretinal membranes. The amount of interference tends to be less. My approach to them is that I tend to say, look, are you having enough of a problem that you want to have an operation? What are the risks? We'll come to the risks of the operation, but it has to be based on that. Here's what we do in it. This is quite interesting because this is stained. It's going to loop around, so we don't need to worry. The retina has been stained with some stuff, and what you've got here is the epiretinal membrane. Now the stains like collagen, and this central bit didn't. Here we go. We're starting again. This central bit didn't really stain because it's more cellular than collagen, and that actually is whilst it's an epiretinal membrane, it shows the peel very nicely, literally like peeling sellotape off a tabletop. This central bit is almost certainly epiretinal proliferation that we'll come to. But you can see this is the internal limiting membrane up here. It's the internal limiting membrane, which has stained. We can grab that, and then we're pulling the membrane across the surface of the fovea. And rather like you take masking tape off a wall or you take sellotape off a tabletop, we're separating the two layers and relieving the two. So that's that one.
Ask another question based on that surgery. What sort of preparation does the eye need prior to you doing this, other than obviously instilling tryptin?
Prep.
Yes. So, what sorts of information will we give the patient as this is most likely what will happen?
Okay. So, what will happen to the patient on the day? Well, firstly, there's the question of cataract. If you do a vitrectomy on somebody who is post-presbyopic, they've got about a 70% chance of developing a cataract in the next 1 to 2 years that needs doing. Now, one thing that's really important to recognize is that the cataract that you get after a vitrectomy, it's a nuclear sclerotic cataract, but it's not brown, it's gray, and it gives index myopia. So when you look on the slit at them, much easier with the dilated pupil. A huge benefit of working in the hospital. Everyone's dilated all the time. I do know that we get it easy. If you look on the slit, you can see a well-defined nucleus, exactly as you would see if it's a brown nucleus, but it's not. It's somewhere on the grey scale. So it's somewhere between, and in no nuclear sclerosis, it'll be black in the center, and in very dense nuclear sclerosis, it'll almost be white. But you're looking on that grayscale. And what happens with that is index myopia. Um, and this is also something that happens spontaneously, particularly, it seems to me, in male myopes. So 50 to 60-year-old male myope who's got a rapidly changing refraction. It's huge and deteriorating vision. It's usually due to that sort of nuclear sclerotic but opalescent nuclear sclerotic cataract. So worth knowing. So one important thing is, are we going to do the cataract as part of it? And routinely on the NHS, I'm offering cataract surgery as part of elective macular surgery, because otherwise they're going to be back for another op. There doesn't seem to be a downside. There's quite a big trial being organised by a lady called Naomi Lois, who's in Belfast, and she's doing the trial to try and show, look at the cost effectiveness of doing both together compared to staged, and also whether whether the results are comparable, because what you want is minimum impact. So you've got that. The biometry we can do because it picks up from the retinal pigment epithelium. So the fact that the retina is the wrong size and shape doesn't really matter. We can get reasonable biometry now, particularly OCT-based biometers, even with retinal detachment. So you've got to basically, in terms of prep, you've got to advise the patient. So it's a vitrectomy. It's typically local anesthetic. You don't need a GA to do this. We need some sort of block, a subtenon's block, which is an injection around the outside of the eye. Typically because we're going to push at the end of the op in order to look at the vitreous base to make sure there's no tears there. So that's a bit painful. So cataract surgery you can do with just drops and a bit of lignocaine inside the eye. Here we need to do a proper block. We also want the eye to be really still while we're doing it. You can imagine if this was a, oh, where are we? If this was a moving target, you can imagine that that would make for a bad day at the office. And sometimes you are trying to do this and the eye is saccading around, and that's just a bit messy, really. So I'm doing that. So the patient has to be able to lie flat for 40 minutes to an hour, let's say. They've day case procedure, local anesthetic, injection around the eye. They're dilated. We would do set up the vitrectomy ports, so the three ports, and I can talk. I've got a slot in September, I think. I can talk about vitrectomies if you want at that point. You set up the three ports that you're in the eye, and the reason you do that is that you don't want to be. You have to push quite hard to get the ports in, so you want the eye to be watertight at the time you put them in. You then do the phaco, put the lens in. The wounds are self-sealing enough that we don't have to suture them. If they're pseudophakic, obviously they don't need cataract surgery, and not everybody wants to have that done. Wants to have their cataract surgery as part of it, and then we can go into a discussion about how we're going to handle their post-operative refractive correction, because this eye is not going to be completely normal. And if they're myopic, we try and work, and you can tell me if this is wrong, but we try and work to less than 4 diopters of anisometropia. Otherwise, we're creating a real problem afterwards, forcing people into contact lenses and so on, or forcing them into having something refractive, be it laser or contact lens or surgery on the other eye.
Can I add another question? Sorry, I'm being very
No.
greedy and asking a lot of questions. So you've put your postlimbal ports in. The cataract surgery is still corneal clear incision.
Yeah.
Yeah. So that would, and you'd still use the same viscoelastics and such that you would use normally.
Oh yeah, cataract surgery looks exactly the same, except that we do a cheeky little posterior capsulotomy at the end of it,
Okay.
because with the cutter from
Mm.
behind, because we can, and because they won't need a YAG capsulotomy at a later date then. And also it makes sure that the view we're getting of the back of the eye is as good as it can be.
Oh, amazing. Thank you so much.
Um, Usually don't put a stitch in the wound, but if the wound's not looking like it's watertight, then we will, because when you're pushing on the eye later, you don't want an iris prolapse, because that's just messy and makes it all longer and not as good outcome. So do that. Peel the membrane, have a look round, make sure there's no tears, either that we've caused or were caused by the posterior vitreous detachment that set the whole thing up. Treat the tears if they're there. That's freezing, or and I can talk about vitrectomy procedures if you want at a later date, with some videos and things. So that's freezing or laser to any tears. Don't typically put air in the eye after. I personally don't put air in the eye after a vitrectomy. Some people routinely do because they think they get less hypotony, low pressure afterwards. I haven't seen that as a particular problem, um, but it may be that I'm just ignoring it. Uh, yeah, so the vision's pretty good pretty soon after. You don't expect the vision measurement to be worse at the first post-op visit, which is the next day. It probably isn't going to be great, but you don't expect the vision to be worse at 2 weeks. Expect it to be better. You expect them often to be aware that there's less distortion. Um, Downsides, well, you can leave some collagen on the eye, on the surface of the eye, because it hasn't yet organized. So you can have some bits where the upper macula's got an epiretinal membrane, and you peel that off, and then 6 months later they come back and they've got an epiretinal membrane at the bottom. And you go back to the scans and there was nothing there, and that's just organized at a later date. So that can happen. So recurrent can happen, persistent, you haven't got it all. But with the stains now, we're much better at seeing where the epiretinal membrane is. And the other one that is, we've got a new toy at Thomas's, which is an intraoperative OCT scanner. So the operating microscope's got an OCT scanner right now. Is that going to make much difference? I don't know. But in theory, you could see if you'd left some epiretinal membrane behind, you wouldn't be able to see if there's collagen left behind. You've got to be a little bit careful when you grab at the retina, because you are reaching down and grabbing the bit of sellotape on the tabletop. You can splash down, you can cause problems with a little scotoma, you can damage the nerve fiber layer when you do that. And if you think about the arcuate distribution of it, you can end up with a corresponding scotoma. About 1 in 100 would end up with a retinal detachment, probably less than that, but there we are. What I quote is 1 in 100. Ongoing treatment, unlikely, but some people who've had an epiretinal membrane peel have cystoid afterwards. About 1 in 1,000 with an elective vitrectomy will end up with a blind eye, and that's from hemorrhage, infection, retinal detachment that we can't fix. The aim is to get the vision about 2/3 the way back to normal, reduce the distortion, and allow the two eyes to work better together. So I tend to do it from a basis of you've got a problem that you want fixed rather than you've got a problem that might be important in the future. And I tell people that this isn't a cancer that we have to treat now in order to stop you running into trouble in the future. This is something that if it does become a problem in the future, we can address at that point. And it's not a cure. So what I spend a lot of time doing is just explaining to people about realistic expectations. You're going to be better if you're closing your eye, if you find your eyes interfering, you're almost certainly going to find that it's not, or it's much less, and you're going to be happier binocularly. But don't expect your eye to go back to normal, because that's going to set all of us up for a fail. Right. What have we got here? Oh, so this is a patient. It isn't the best image, but it's one I got last week. You can see the epiretinal membrane here, and it's nice and thick and high signal. You can see the corrugations. We can see the secondary cystoid. This is It's not great. It's a bit subtle. Do you see the sort of fine fingerprint on the surface of the retina? There's the blood vessels, obviously, but then on top of that, we've got the fine fingerprint. That's the striae, and those striae correspond to the corrugations. So that's it in the X and Y axis, and this is it in the Z axis. So do look at your on fast view as well, because there's a lot of useful information in there. Um, this this is after surgery, and we can see that there's the little cysts there. The cysts persist for up to years. This image, it's the same guy, and those of you who are, you can see his drusen are getting worse at the bottom level, his intermediate AMD. I'm sure Moyne's told you about that. Then we've got, that's got a bit worse there, and they've got a bit worse here. But his cysts have gone, which is good. His cysts have gone. This little notch here, that's called donful, and that's dissociation of the nerve fiber layer, and you get that from peeling. What I'm hoping, what's happening? No, what's going on? Ah, yeah, it's not the best before and after image. I'm sorry, I meant to get a better one today. You can see that this blood vessel's quite dragged in. This one's dragged in there. What you see on the Heidelberg, I don't know if any of you have got the Heidelberg in practice, but on the Heidelberg, you can select an image and you can flick between before and after. And I'll show you a video of that in a minute. And what it's brilliant showing this, and this is actually, to my mind, the most effective way of showing people what's happened to their retina, because you literally see the post-op, pre-operatively, the vessels are sort of pulled inwards because it's all contracted in. Oh, it's all contracted into the center. And after the peel, you can see it's opened up. It's sort of boom, boom, and you can watch it just flicking backwards and forwards. You can see I've left some collagen behind here. You've still got those striae there, but generally, I mean, it's not a great example. I should have got a better one. I'm sorry. Everything's opened up, and the XY distortion is less, and the Z-axis distortion is left. So I think the main thing here is looking both the X, the Y, in the X, the Y, and the Z-axis at the images. Right. Somebody can answer that. Any questions about epiretinal membranes?
I've got a question, if that's
Yeah.
okay. I could be wrong, but I think I've read that a large proportion of ERMs can spontaneously resolve, although I've never seen that. How common would you say that is?
Yeah, they can. Right. So the circumstance in which an epiretinal membrane spontaneously resolves, and it's not a large proportion, is if you've got vitreomacular traction, so you've still got the posterior hyaloid, the back edge of the vitreous, on the surface of the macula. Now it's separated and distorted, you've had some schisis, and you've got organization of that. And sometimes you can have a really impressive looking epiretinal membrane, and then you develop a posterior vitreous detachment, and they do their own peel. And then in those people that have got that, you've usually got a whopping great floater on the posterior hyaloid face. So you've turned sometimes one problem into another. So yeah, that can happen. If we go back to this, where are we? There, that's not going to go away. The vitreous is gone. There's nothing to mechanically peel that off other than my pair of forceps or someone else's forceps.
Yeah, thank you.
I think we might have an image that'll show that a bit later in some ways. Any others on epiretinal membrane? So referral threshold, as far as the epiretinal membranes are common, really common, 7% of the population or something. So referral threshold for me is symptoms. If they're asymptomatic, very nice, you've got that. If it's a problem, the hospital will be interested in seeing you. If it's not affecting your vision, carry on. We good on that? Any other?
I think that's really helpful, actually. We often quite find we have patients that are troubled by their ERMs, but are they troubled to the point that they are willing to take surgery? And in cataract point of view, we often find that patients are wanting to have the consultation, but not necessarily wanting to have the surgery. Is that something that you experience at hospital? That patients are coming in because they've got an epiretinal membrane and they've been told they've got an epiretinal membrane, and when you give them the information about the surgery, they then balk.
Well, I've got two killer questions. Does it matter? You know, so you've got impaired vision in your left eye. Does it matter? And I try and put it nicely rather than bluntly. And secondly, is your bad eye interfering with your good eye? And if no, I'm not aware of it, both eyes open day to day. Usually I'm steering the conversation towards, well, if you do get into that position, we'll be happy to deal with you. But right now, both eyes open, you probably won't know there's much change. So that would be my sort of take on that. In terms of referral, there's a lot of them out there. It's something like 7% of the population. But you know, if they're worried about it, want to talk about it, that's fine. But the basic premise is the threshold is symptoms.
Thank you.
So, lamellar macular holes. Now, these are interesting, and our understanding of these has changed hugely over the last sort of 10 years, mainly down to a guy called Andrea Gavetto, who works in Milan. He's the most lovely bloke. Genius. Now, so a macular hole, a full thickness macular hole, there's a hole all the way through to the retinal pigment epithelium. So there's a split in the photoreceptors. That's obviously not here. You then got something which, when you look at it en face, you see something circular. And people talk about pseudo-holes, they talk about lamellar holes, partial thickness holes. And basically now I think we've boiled it down to lamellar holes and full thickness holes. But if you've got an alternative and want to throw in something, do let me know. Now, there's two different basic forms. This is what is this one on the right is basically the pseudo-hole. We haven't lost any retinal tissue. Is the first thing. That, you know, the bottom of the foveal depression is roughly where it should be. We've got a high signal on the inside, really important. And we've got splitting, a tractional maculoschisis, traction, pulling, macula, schisis split. We've got a tractional maculoschisis between the outer nuclear and the outer plexiform layer. So these are the connections. And I don't know where you've got your pictures of all the attendees. There's a risk of this covering it up for me, so I'm just fiddling it out of the way. So you can imagine that's a bit of a French moustache on the tractional front. Now, degenerative holes is it's something completely different. It's a different condition, but interestingly, well, it's not a different condition. It arises out of standard epiretinal membranes. But what you've got is a metaplasia and proliferation. And the extra layer of stuff on the inside, which you can see here, is hyporeflective. An epiretinal membrane is bright white. And if we go back, let's get out of there. If we go, no, that's the wrong way. If we go back to that one, it's bright white. If we go back to these, they're bright white. Okay, so standard fibrotic epiretinal membranes are bright white on the inner surface, presuming that you've got your grayscale oriented this way. Interesting, in this publication, they were oriented the other way, so I had to find a bit of software to flip it. But you've got this extra layer of tissue on the surface there. And this is called epiretinal or epimacular proliferation. And it's the Muller's cells, which have gone a bit splar. You then get this sort of odd cystic change, and you get a central degeneration of the retina and loss of the outer signal. Now, this is all basically down to the Muller's cell cone, and most of this isn't actually retina itself. So let's have a look at some pictures. This is the tractional style, high signal, high signal, high signal, split here, outer part pretty much fine. Here, low signal, but definite extra layer of tissue. And once you've seen it, you can't unsee it, but until you've actually had it pointed out to you and applied to me, when somebody pointed out to me, I said, how many of those have I missed? You know, here it is, there it is. And you get this in macular holes as well, the same. And then here, if you look at this, that's not the same as the outer nuclear layer there. And that's not quite right. This has got a different reflectivity. And so this is proliferation of the Muller's cell cone there. And this is proliferation of the Muller's cell cone on top. So you can imagine here that the retina, I'm just going to sketch out where this retina is going. It's going from there to there, and that's all some extra stuff in there. So this is, you've got the three components of the degenerative lamellar hole. You've got the epiretinal proliferation, you've got the sort of cystic-y bowler hat edges type of holes rather than stripy type here, which is obviously schisis, splitting and tractional splitting, and then you get an outer retinal change. And the amazing thing is, and this is from Peter Wiedemann's group in Germany, here you can see that traction on the outer part of the retina through the Muller cell cone. But this is the same eye over 91 months, whatever that is, 7 years, 7.5 years. Epiretinal membrane, high signal. Epiretinal membrane, high signal. It's changing to low signal. We've got a bit of central gliosis, some people say, and that would almost do for a macular hole, wouldn't it? If the gap was a bit bigger. And then we start to get these cystic-y changes around here, much more internal proliferation. Then we've got lots of that, and the middle's looking very unhappy there. And so this is sort of the evolution. So this is the Muller cells, which are these little things that support and look after the macula, other than the three neuron chain. They've been upset and they're proliferating. So it's sort of almost inflammatory in some ways. So here is the Muller cell cone, described by this amazing bloke called Don Gass, who died many years ago. But Don Gass described just about everything in the macula, and these was in the days when he was doing it with either a 90 diopter lens, or I don't know if any of you have seen it, the tiny little Goldman macular contact lens, which is basically a flat topped lens. It's about 15 millimeters in diameter. You put it on the eye, and then with the slit lamp, you can see in very good 3D what's going on at the macula. We still use something like that for surgery some of the time. But he described all this from basic principles. But here you see the Muller cell cone. As you see, it looks like a whale's tail or a golf tee sitting there, and it holds the fovea together in the center. So it's sort of the hub in the wheel. If you think about a bicycle wheel with spokes running in, you've got the hub in the middle. The Muller cell cone is the hub. And so you have to interrupt your Muller cell cone to let everything split apart. It's where the xanthophyll sits as well. Important role in lamellar holes, full thickness holes, and vitreomacular traction. So they're again, down here, you can see this is the wrong grayscale to be the outer nuclear layer. This is extra stuff, so it's proliferation of that. So when you peel it, this isn't a video, when you peel this stuff, it's completely different to peeling in lamellar macular holes. It's completely different to peeling an epiretinal membrane. An epiretinal membrane, it is an epiretinal membrane, but it's a different type. An epiretinal membrane, the typical one, is like taking sellotape off a Formica top. You grab it, you peel it, it's crispy, crunchy, and it comes off. This is like trying to take chewing gum off wet newspaper. It's completely different. And I don't know if you can imagine, this is very cellular. These are the forceps. This is the edge where it's been peeled. It's very yellow due to xanthophyll. And you almost feel like you're peeling a layer of the retina because it's difficult. And the other thing about this, as you saw in the previous thing, is that it doesn't stain very easily. So we can't turn it bright blue in order to see exactly where it is. So you almost counter stain, that you stain the stuff outside it and then grab it and peel it. So the amazing thing about the melomacular holes is that with surgery, they completely change. Now, you'd kind of think that these holes ain't going to go away, but you peel this membrane, you fill it in, and the cysticky bits go. And I didn't believe this when I first heard it described. I thought, no, that's just not going to happen. This is degeneration of the outer retina here. This is loss of inner retinal structure. But you peel it, and lots of people actually sort of stuff the material into the hole, although whether you need to do that or not, I don't know. And there you can see the material that's been stuffed in. But the cysticky spaces have gone. And it does work. So if people have got distortion and impaired vision, even with the melomacular holes, it is worth offering them surgery. And it does work, which I was amazed at when I first found out about it. Most are relatively asymptomatic. Some will progress. The outcome data on it are far from robust, so there aren't any randomized trials. You know, if you go, there's a series with maybe 60, 70 cases in it before and after. Well, what about the ones who weren't submitted for these trials, for this study, and so on? But it does seem to improve the acuity. And the other thing is, I think that this is progressive. The secondary outer change is progressive. And in some of them, you'll see they can go on and form full thickness macular holes. So I think that there is a potential role in symptomatic patients of doing the surgery. But again, threshold symptoms. What's next? Yeah. Okay. So that would be the lamellar holes. Any questions on that? Happy?
Absolutely. Time check, it's nearly 1:45.
How much longer do you want me to?
So generally we go
faster?
on for another 15 minutes.
Okay.
But it depends on you and our participants. So if anyone is happy for it to go over, then please do let me know. And if you're happy, if you'd prefer not to, then please let me know in the chat. Otherwise, 15 minutes, Mr. Laidlaw?
Yep, right. Let's get a move on.
Perfect, thank you.
So vitreomacular traction, again, maculoschisis. So vitreoschisis, there's the layer of vitreous there. There's the front layer of vitreous, Muller cell cone being pulled up. And you can literally see the Muller cell cone being hauled out of the retina there. Sometimes they have a vitelliform associated with them. I think often that the vitelliform's the more important thing, particularly if they're big like this. They've usually got a little lump there as well. And the macular traction secondary rather than the other way around. But this, I would say, was tractional. That, I would say, was vitelliform macular degeneration. But you're getting that. And again, it's the apex of the Muller cell cone that's being pulled on. Intervention threshold surgery is symptoms. Ocriplasmin, I can talk about ocriplasmin for hours. We don't use it. Terrible stuff. Referral, symptoms. If they've got it and they're asymptomatic, don't refer. If they develop symptoms, refer. A small proportion, as this one did, go on to forming a macular hole.
Can I ask a quick question on, sorry, I'm interrupting you. On these sorts of things, referral through, unfortunately, because of how many people need to be seen at the hospital, we have the option of urgent or routine. And routine to VR, you know, we're looking easily 3 months, if not longer. And urgent, so where would this sit? Say, for example, you've got a symptomatic VMT, urgent or routine?
Routine, because it might go away on its own.
Perfect. Thank you.
And a large proportion do go away on their own. And if the vision suddenly falls off a cliff because they've got a macular hole, then turn it to urgent or tell them to go to casualty, which is always the backstop for the patient who needs to be seen. Take their sandwiches and go to ICAS. Yeah, but most vitreomacular tractions, even if symptomatic, firstly, the vast majority are not symptomatic or are minimally symptomatic. Secondly, so I've operated on very few of these because on the whole, patients aren't that concerned about it.
Brilliant. Thank you.
Oh, here we are. There's a, this should be a video, right? That's showing, this will just loop. That's, you saw that Muller's cell cone being hauled out of the retina. You can see it at the bottom there. And this is, you know, the vitreomacular traction, and this is on its way to forming a full thickness macular hole, which it did. There you are. You can see on the left-hand side that it went on to form a full thickness macular hole. There. Okay, that one's running a bit fast. And you can see the vitreomacular traction that underlies it because the hub was pulled out from the spokes. Right. Most macular holes are vitreomacular traction related. And here we see the Muller's cell cone. We see the vitreous pulling on it. We see the gap and the little end of it. Think about Tower Bridge. Remember that we've got a really exaggerated Z-axis. If you put your fingers together on the table like this, and then you do that, you open a gap. So it's Tower Bridge. The inner part of the retina is pretty stiff, and it flicks a bit like an umbrella turning inside out. And that's what's happened here. Most of them are tractional, some are cystoid macular edema related, and in about 1 in 6, you'll see the epiretinal proliferation. So I think that they are actually a progression from an epiretinal membrane, epiretinal proliferation, and then macular hole. They've got a rather different natural history. My impression is it tends to be blokes, but we need more evidence on that. So size is of the essence because that dictates what we do to fix them. The average size is about 400 microns. What do I mean by size? I mean the largest gap that I can find. So it has to be across the largest diameter. Well, the diameter has to be, rather than a chord, the diameter of the hole is the size at the inner, the biggest, smallest gap is the way I put it. So up to 400 microns is average. And then beyond that, they get big, and some of them get huge. And depending on where you work and what your population base is, you sometimes see people coming in who've had macular holes for most of their life, and they've been up to 1,500 microns in size. Others, you know, the typical sort of 70-year-old white lady who's a little bit hypermetropic, who develops a macular hole, by the time it's symptomatic, they present symptomatic, it'll probably be 250 to 400 microns. Size relates to chronicity, and the vision's worse. The bigger they are, the worse the vision, funnily enough. The distortion's interesting because the photoreceptors don't know where they are, they know where they want to be. So if you move them up and out, they think everything that was out there they see as being in there, which is why everything compresses and barrels in. And that explains the distortion. They don't actually lose vision. It's this idea that you can get a break, Watsky-Allen sign, that's just forcing people to see what you want them to see. That's not actually what they see. If you put a laser aiming beam with the laser turned off, you put their laser aiming beam there, they won't see it. But that's different to doing a Watsky-Allen test. So what do we do? So I'll crack on. So we do a vitrectomy and ILM peels. So first of all, vitrectomy. This has been stained with triamcinolone. Reach into the eye, pull, and up comes the posterior hyaloid from the surface of the retina. So this is the stained posterior hyaloid. We then gobble it up to get rid of it. Try not to create any tears. We then stain the surface of the retina with blue dye. It's the same blue dye that's in Smarties. And this stains the collagen of the internal limiting membrane. It'll hoover out in a second, maybe. No, it won't. Okay. Then we do an ILM peel. And again, we've got the counter stain here where it hasn't stained. That's because there's some extra stuff there, but this is a really heavily stained membrane. And you can peel off the internal limiting membrane. That's the heads of the Muller's cells. It's the basement membrane of the Muller's cells. So they're going out as you do this. But it gets rid of all the collagen. It creates some controlled injury, and it is fundamental to getting holes to close. Right, we then put some gas in the eye, fill up the eye with gas, and then there's different gases used. So this is filling it with air, and then we swap that for gas. Right, so now other things about macular holes, to wrap this up. ILM peeling essential, it seems, certainly in 300 microns and bigger. They don't close if you don't. In smaller holes, you might get away without doing it. Once you get beyond about 550 microns in size, we have to start doing something extra. And so other techniques come in, and some of you may have heard of these. We can do what are called ILM flaps, which is where instead of taking the ILM away, we actually flap it over the top. All of the principles are that you're trying to occlude the hole, to stop the flow through it, to turn Tower Bridge from that to that. So that's the principle of what we're trying to do. The gas bubble, you want more than 2/3 of a fill of gas for about 5 days. And gas bubbles are not spheres within the eye. They form a spherical cap being take a sphere and chop the bottom of it. That's a spherical cap. And as long as you're more than 2/3 filled, the hole is covered in a straight ahead looking position. So face down, first, there's no evidence that face down helps. Secondly, if it does help, it might be not because you're maintaining contact of the hole, of the gas bubble with the hole for longer during the day, because they're looking down and not wobbling their eye around. So if you've got an underfill, and the technical terms are sloshing and splashing. If you want to think about sloshing and splashing, take a Paris goblet, fill it 2/3 with red wine, and then walk around the room, and the surface will slosh and splash. If it's half full, you'll see that your hypothetical macular hole on the widest part of it will be uncovered a lot of the time. So the gas bubbles, air lasts about 5 days, C3F8 lasts about 10 weeks. There's not a lot of evidence that C3F8 is any better than air, but very few people would have the courage to do that. Hole size dictates the outcome. With bigger things, we put bigger flaps in. And again, realistic outcome measures. We can close the hole or make it go flat. Huge holes, you can't get it to reoppose. You can put some tissue in there. Might be amniotic membrane, might be, people have used bits of retina as well. That's rather heroic. But you can occlude the hole. But the idea is to get the edges of the photoreceptors down. And if you've still got a gap, well, there you are. Right. Boom. So run through 57 minutes, sorry. Epiretinal membrane, lamellar hole, vitreomacular traction, and then full thickness macular hole. What's important? Symptoms. The differential diagnosis, but actually, if they're symptomatic from their macula, they're going to have impaired vision and distortion, and the eyes are going to interfere with each other, and that's where we're really interested, because we can do something to help them. Surgical outcome, realistic expectations. People go 2/3 of the way back to normal after surgery is a good aid memoir. PVD and vitreoschisis are important, and my favorite topic, the Muller cell cone. Thank you.
Thank you so much. That was amazing. I've learned so much. Did anyone have any questions? Or is it just me that has all the questions?
Can I ask a question?
I had a couple of questions, if that was all right.
Yeah, do
Yeah.
Thank you. It was absolutely amazing. Completely agree. So two things.
Why don't you turn your cameras on and we can interact with it?
Oh God.
Everyone hate that.
Sorry, it's too late in the day for a camera. I do apologise.
Yeah, I know the feeling.
Yeah, sorry, two things. The first is, what is your opinion on vitriolysis for floaters? Obviously, I know it's not available on the NHS. And secondly, also your opinion on a supplement called Vitro-Cap-N for floaters.
Well, on the second thing, absolutely no evidence. Yeah, so it might be good, it might be terrible, it might be dangerous, it might be the best thing since sliced bread. We have no way of knowing unless it's put to a randomized trial with objective outcome measures. We're left with the people, I think they're German, aren't they, who developed it, claiming what it does. You know, it's a bit like all these supplements for macular degeneration. It's only the AREDS 2 formula that's been shown to work. The rest of it might be hypothetically effective, but we don't know. YAG laser vitriolysis, yeah, unproven. What we really need is a randomized trial of doing it. If you look up the results, firstly, people who do YAG laser vitriolysis are usually people who can't do vitrectomies. Secondly, people who can do vitrectomies tend not to do YAG laser vitriolysis. So you've got biased samples. On the evidence that there is, YAG laser vitriolysis is associated with complications, both retinal detachment, and some people have reported very high pressures. My experience of vitreous floaters and floater surgery is that the people who want it have usually got huge clumps of teased out cotton wool in their vitreous that is drifting around, rather than having a single discrete vice ring. And the videos that you see on the internet are of somebody blasting apart discrete vice rings, not the big cotton wool ball opacities. So I also know from experience that if you do a vitrectomy and somebody's got a posterior vitreous detachment, and lots of people with floaters don't, if you do have a posterior vitreous detachment, the eye ends up gin clear. You can also combine it with a refractive procedure, and we do a vitrectomy on the NHS for floaters. You can combine it with a cataract op, and they do end up with absolutely amazing vision, and it's a low detachment rate and highly effective. If the vitreous hasn't separated, the people who've got floaters, I think, are quite high risk. They're quite high risk of epiretinal membranes, of macular holes, and of subsequent retinal detachment. And they're often youngish blokes, middle-aged blokes, who've got teased out cotton wool in their vitreous. So I'm quite cautious with people about the risks. Can I tell you whether vitriolysis it should be done first? I don't know. There's a guy called Larry Benjamin who used to work up at Stoke Mandeville, and he presented a series, one of the few series from somebody who can do vitrectomy and laser, and basically his conclusion at the end of it was that you can do a lot of laser and turn big floaters into small floaters, and then a large proportion still want a vitrectomy. But that is a really, really biased viewpoint, because I haven't had the facility to do the laser.
Thank you. Thanks.
I think there was somebody else wanted to ask a question as well. So
It was
please,
me.
please do.
I just had a question. I had a patient recently, and I can't remember the details, but they had macular schisis from an epiretinal membrane, and they'd been prescribed Maxidex. And I just never heard of that before. I didn't realize there was an inflammatory component.
Yeah, you and me both, I think. Right, so cystoid macular, they've got I've got a brother-in-law who's an optom down in Taunton. He keeps sending me cases, and I know fine well that he's working at a higher level than many people who are working in eye clinics, and it may well be that you're one of them. You've got cystic change does not necessarily equal cystoid macular edema. Now we use Maxidex in order, and Acular together, or non-steroidal steroidal in cystoid. if we think it's inflammatory. So pseudophakic cystoid, so people who get swelling after surgery. If you put intravitreal steroids into an eye that's got an epiretinal membrane and some swelling, you will make the retina thinner, but it all comes back. So yeah, if it's attractional maculoschisis, I think you might have drops might have been there to see what happened, whether they remain symptomatic long enough for a referral. I don't think it was going to work.
Brilliant.
I've told in one of my colleagues, have I?
Yeah. It's a bit
I have
controversial.
no idea who it was.
Oh, thank you. Was there any other questions? No. I have an additional question. And this is quite often the case, certainly if they've done, if someone has done VR surgery and cataract surgery, is when is the optimum time for them to be refracted? Because quite often we have to kind of put the brakes on patients, and they argue with us. And so it's quite nice to sort of say, well, actually, there's a sensible reason we need to wait.
Well, the refraction's not going to change very much. So we've done the cataract surgery. You're probably going to be wanting to do a refraction a month, 6 weeks after cataract surgery. So the astigmatism and so on should be all settled, stabilized roughly at that point.
Yeah.
Their vision might continue to improve, but their axial length and their lens position and their astigmatism should remain fairly stable. So again, it's slightly expectation management. Yeah, I can focus this eye, but you're still going to have some distortion. But that is just getting better. It's a geometric decline. It's getting 30% better per unit time and keeps getting 30% better per unit time until it stops. That's the amount that it can get better. So it's a law of diminishing returns.
Okay. Brilliant. Thank you. I think that's all the questions. There was no questions in the chat. Everyone is just quickly saying thank you. I'm going to stop recording.